Hello dear students, I am Dr. Fikrət from Department of Urology of Azerbaijan Medical University. These days our university has started its new online education system just because of COVID-19 pandemic. This is the new practice in our history of our department. And I also would like to add that I believe we will pass this pandemic quickly. Now let's start to our first lecture of urology. Our first lecture of urology is the history of urology and non-specific infections of the genito-urinary tract. Urology and the history of urology in the world. When we talk about urology, also known as genito-urinary surgery, is the branch of medicine that focuses on surgical and medical diseases of the male and female urinary tract system and the male reproductive organs. Organs under the domain of urology include kidneys, adrenal glands, ureters, urinary bladder, urethra, and the male reproductive organs. Although recognition of urology as a separate specialty or subspecialty of general surgery is relatively recent, evidence of many diseases and even some surgical procedures dating to ancient times have been discovered. Diseases that later came under the purview of urology. Bladder stones have been found in Egyptian mummies, dating to several millennia before Common Era, and the rite of circumcision is thought to have been practiced in Egypt as early as 4000 before Common Era. The Oath of Hippocrates, dating to 5th century before Common Era, includes the following provision: I will not cut even for stones, but will leave such procedures to the practitioners of that craft. The practitioners referred to by Hippocrates tended to be concerned primarily with bladder stones, which are known to have been common in Middle Ages and the Renaissance. These stones, which were probably due to dietary deficiencies and bladder outlet obstruction, were usually found in men. One of the oldest urological documentation describes a bladder stone dating back to 4800 before Christ, which was found in grave of 16-year-old boy near Egypt. At the end of the pre-Christian era, ancient Hindu surgeon attempted to remove bladder stones through a suprapubic incision, but the operation lapsed until 1556, when Pierre Franco successfully performed this procedure on a child. 2 centuries later, the preferred approach was the perineal approach for bladder stone. At that time, the death rate was considerably high and a large number of complications could be expected, especially urinary fistulas and incontinence. One French lithotomist, known as Pierre Jacques, was said to have performed this procedure in 45 seconds as a record of all time. In this slide, we can see the lithotripsy. This is one of the first lithotripsy in the world. It used in 1840s. This is some instruments we can see here for stone removal from the bladder. This is lithotomy forceps, which have been used between 1815s to 900s. Around 1820, surgeons discovered that it was possible to insert a straight catheter into the male bladder. This formed the basis of transurethral stone crushing and lithotripsy, which opened up the way to a more gentle treatment. This procedure for crushing a bladder stone is known as a lithotripsy. First was performed by 1824 by Jean Clade in France. These and other steps in the evolution of urology as a specialty were forerunners for a number of developments in the 19th century, developments that marked the beginning of separation from the discipline of general surgery. Although the two remained closely associated, in addition, urology was closely associated with dermatology during that time. However, urology as a specialty in its own right was only instituted in 1890 with the appointment of Félix Gouyon in Paris as the first professor of urology. One of the first dedicated urologists, Dr. Edward, began his career as a professor of dermatology. Dr. Case was organized and first president of the American Association of Genito-Urinary Surgeons in 1888. Perhaps one thing that contributed the splitting of urology from general surgery was the development of cystoscopy in the 19th century. Beginning in 1807, a number of instruments were devised to peer into body cavities. But it was not until 1877 that Max Nitze, in collaboration with an instrument marked in Dresden, fabricated the first cystoscope. The cystoscope was improved only after the invention of the incandescent lamp by Thomas Edison, 1880, and miniaturized later. This is a cystoscope which Nitze used and invented. This is invented in 1889. The crucial breakthrough in the mid-1950s was the development of the Hopkins rod lens system that revolutionized urology by providing robust, versatile, reliable, and sterilizable endoscopic equipment and cold light source, which allowed high-quality visualization of the inferior of the genito-urinary tract. The later addition of fiber optic, flexible endoscopes and endoscopic video cameras further enhanced operative urology. Now we can move on the history of urology in our department in Azerbaijan. The Department of Urology of the Azerbaijan Medical University was established by the initiative of Dr. Sudeyv Imanverdiev on March 1975 on the basis of the 60 beds Department of Urology of the Republic Clinic named after Mir Qasimov. This is the clinic named after Mir Qasimov, and this is our old urology department in that clinic. This is our professor Nurali Efendiev. In 1977 the division of urology of the Central Hospital of Azerbaijan State Shipping Company, envisaged for 45 beds, also became part of the department. In 2014 was opened new 13-floor hospital building in Azerbaijan Medical University. Now we have a lot of opportunities to teach the students and residents as well as urological researchers. So the Surgical Hospital of Azerbaijan Medical University we can see here in our teaching hospitals picture. After establishment, Nurali Efendiev was appointed the head of department. He graduated Azerbaijan Medical University in 1946, and he defended the thesis of indication for adenomectomy during BPH, and in 1962, and for a doctor's degree partial nephrectomy at some disease of kidney in 1969 in Moscow. Professor Efendiev had been leading the department until 1990. In 1990, Professor Imanverdiev was elected the head of department. It has made a great contribution in the development of Azerbaijan medical urology. He was born in 1938 in Azerbaijan and graduated of Azerbaijan Medical University in 1962. In 1968, in Baku, he defended the thesis role of lymphography and intraosseous pelvic sonography in the treatment of bladder, prostate, and external genital organ tumors in Baku. This is our head of department, Professor Imamverdiyev. This is the image of lymphography, and this is pelvic phlebography and lymphography. Between 1972 to 74, he was sent to Moscow for participating the state surgery center under leadership of Russian urologist Petrovsky. In Moscow, he defended his thesis for a doctor's degree, surgical treatment of vasorenal hypertension while artery disease of both kidneys in Moscow. In 1974, from 1965 till 71, he was assistant of urology, Department of Azerbaijan State Postgraduate Institute. In 1976, he worked as an assistant professor in Azerbaijan Medical University. In 1977, he was elected the professor. He invited 13 new techniques for different urological operations. Within 1970s, complex vascular observations became widely spread in Azerbaijan as a result of activity of the urology department. In this slide we saw autography. In 1979, kidney autotransplantation was successfully performed at the department for the first time in Caucasus. One of the actual departments in urological practice is still the surgical treatment of nephroptosis. 3 nephropexia methods have been proposed at the urology department, taking into consideration the character of changes in kidney and surrounding tissues. In 1991, the urology department prepared and applied method of transperitoneal repair of the vesicovaginal fistulas. Some surgical operations during complicated cases of this pathology were successfully performed and provided further effective results. Successful surgical operations in case of kidney stones, reconstructive operations of the urinary system of children and adults, complicated urological fistulas of females were possible to implement in urology department. Prostate biopsy and radical prostatectomy method was introduced at the urology department for diagnosis and the treatment of the prostate cancer in 1995. Since 1999, the department has been successfully performing the transurethral resection of prostate, organ preserving during kidney tumors, transvaginal tape, and other major and minor urological operations. We also wish to note that the Department of Urology since 1977 is unique clinic where regularly performed radical cystectomy with various techniques of urine derivation. The Department of Urology has also made a great contribution in development of andrology in Azerbaijan, being considered a difficult disease in urology. Practice prepism, Peyronie disease, which causes erectile dysfunction of middle-aged and elderly people. For the first time in Azerbaijan, extensive researches were carried out to study the complications caused by this disease. In our department has been published over 280 scientific articles, 7 monographs, 5 manuals, and 1 textbook in recent years. Within this year, our Department of Urology have been prepared more than 25 PhD doctors, Doctor of Medical Sciences, and professional urologists which successfully work as urologists in Azerbaijan and is far behind its limits. Our department also accepts resident urologists every year as a teaching hospital. Thanks to effort of the Department of Urology and the support of European Association Urology, we have organized in Baku the first ESU course in October 2009. We also continue working closely together with European Association of Urology team. This is some of our published articles which have been published in European Urology journal. This is our department, some of our urologists, and those are main equipments which we use during our urological procedures. The first one on the left, on the upper left, we see flexible cystoscope. We can examine with this one inside the bladder, and the second one from the up, we see cystoscope, which we can, this is a rigid cystoscope, we can examine again urinary bladder with this instrument. And third one on the first line, we see ureteroscope. With this rigid ureteroscope, we can from the urethra we can go up to the kidney, and we can find this stone, and we can perform lithotripsy with this instrument. And this one is flexible ureteroscope, which we can perform stone lithotripsy with the help of laser in the kidney with the help of this instrument. We can travel all the calyces in the kidney with this flexible instrument. And the next instrument is nephroscope. We can break the crush and do stone lithotripsy inside the kidney with this rigid nephroscope. And the last picture shows the resectoscope. With this resectoscope, we can perform prostate operation endoscopically and transurethral resection of bladder tumors. And this is a monitor system which gives us the view of the procedure during the operation. And now I can move on the second part of our lecture. In second part, I will talk about non-specific infection disease of the genito-urinary tract. When we will talk about non-specific infections, we will talk about kidney infections, which includes mostly pyelonephritis, bladder infections, cystitis, prostate infections, prostatitis, prostatic abscess, urethritis, epididymis, and orchitis. Urinary tract infection is a term that is applied to a variety of clinical conditions ranging from the asymptomatic presence of bacteria in the urine to severe infection of the kidney with resultant sepsis. This chart shows us epidemiology of UTI by age group and sex. Incidence has shown in percentage. Pathogens and bacterial entry. There are 4 possible modes of bacterial entry to the genito-urinary tract. One and most common one is ascending way, and the other ways are hematogenous, lymphogenous, direct extension of bacteria from adjacent organs are seen in rare cases. It is generally accepted that periurethral bacteria ascending into the urinary tract caused by UTI. Most of the pyelonephritis are caused by the ascent of bacteria from the bladder through the ureter and into the renal parenchyma. Consequently, the short nature of female urethra combined with a close proximity to the vaginal vestibule and rectum likely to predispose women to more frequently UTIs than men. Hematogenous spread can occur in immunocompromised patients and in neonates. Lymphogenous spread through the rectal, colonic, and periurethral lymphatics has been postulated as a cause of UTI. However, currently there is a little scientific support to suggest that dissemination of bacteria through lymphatic channels plays a role in the pathogenesis of UTI. Direct extension of bacteria from adjacent organs into the urinary tract can occur in patients with intraperitoneal abscesses or vesicointestinal or vesicovaginal fistulas. Causative pathogens. Most UTIs are caused by a single bacterial species. At least 80% of uncomplicated cystitis and pyelonephritis are due to Escherichia coli. Other common uropathogens include Klebsiella, Proteus, Enterobacter, Pseudomonas, and Enterococci. UTIs caused by Staph aureus often result from hematogenous dissemination. Group B, beta-hemolytic streptococci can cause UTIs in pregnant women. Staphylococcus saprophyticus, once often thought of as urinary contaminants, can cause uncomplicated UTIs in young women. In children, the causative bacterial spectrum is slightly different from that of adults, with Klebsiella and Enterobacter being more common cause of UTI. Acute pyelonephritis. Acute pyelonephritis is defined as inflammation of the kidney and renal pelvis, and its diagnosis is usually made clinically. The presentation and findings in acute pyelonephritis. A patient with acute pyelonephritis presents with chills, fever, and costovertebral angle tenderness. We do this examination and tapping on patient's lumbar area. If there is a positive angle tenderness test, then we more diagnose the acute pyelonephritis. They often have accompanying lower tract symptoms such as dysuria, frequency, and urgency. Sepsis may occur from a urine infection. Urinalysis commonly demonstrates the presence of white blood cells and red blood cells in the urine. Leukocytosis, increased erythrocyte sedimentation, and elevated level of C-reactive protein are commonly seen on blood analysis. Bacteria are cultured from the urine when the culture is obtained before antibiotic treatment is instituted. E. coli is the most common causative organisms, accounting for 80% of cases. Radiographic imaging. In patients with acute pyelonephritis, renal ultrasonography is important. Rule out concurrent urinary tract obstruction, but cannot reliably detect inflammation or infection of the kidney. Contrast-enhanced computed tomography scan can accurately demonstrate finding, confirming the diagnosis of pyelonephritis. In this computed tomography image, we can see the acute pyelonephritis. This white arrow shows that acute pyelonephritis in the right kidney. Management. The management of acute pyelonephritis depends on severity of infection. In patients who have toxicity because of associated septicemia, hospitalization is warranted. Approximately 10 to 30% of all adult patients with acute pyelonephritis require hospitalization. Empiric therapy with IV ampicillin and or aminoglycosides is effective agent against the broad range of uropathogens, include Enterococci and Pseudomonas species. Alternatively, amoxicillin with clavulanic acid or third-generation cephalosporins can be used. Fever from acute pyelonephritis may persist for several days despite appropriate therapy. Parenteral therapy should be maintained until the patient temperature normalizes. If bacteremia is present, parenteral therapy should be continued for additional 7 to 10 days. And then the patient should be switched to oral treatment for about 2 weeks. In patients who are not severely ill, outpatient treatment with oral antibiotics is appropriate. For adults, treatment with fluoroquinolones or trimethoprim sulfamethoxazole is well tolerated and effective. Therapy should continue for 2 weeks. In some patients whom acute pyelonephritis develops, will require radiologic examination such as voiding cystourethrogram or cystoscopy. Now we will talk about emphysematous pyelonephritis. Emphysematous pyelonephritis is a necrotizing infection characterized by the presence of gas within the renal parenchyma or perinephric tissue. About 80 to 90% of patients with emphysematous pyelonephritis have diabetes. The rest of the cases are associated with urinary tract obstruction from calculi or papillary necrosis. Presentation and findings. Presentation with emphysematous pyelonephritis with fever, flank pain, and vomiting that fails initial management with parenteral antibiotic. Hematuria may be present. Bacteria most frequently cultured from the urine include E. coli, Klebsiella, and Enterobacteria. The diagnosis of emphysematous pyelonephritis is made after radiologic examination. Gas overlaying the affected kidney may be seen on a plain abdominal radiograph or kidney ureter bladder film. CT scan is much more sensitive in detecting the presence of gas in the renal parenchyma than renal ultrasonography. In the management of emphysematous pyelonephritis, prompt control of blood glucose and relief of urinary obstruction are essential. In addition to fluid resuscitation and parenteral antibiotic. The morbidity rate is about 11 to 54%. Poor prognostic factors include high serum creatinine level, low platelet count, and the presence of renal perirenal fluids in association with a bubbly loculated gas pattern or gas in the collecting system. In combination with medical treatment, percutaneous drainage appears to be helpful in accelerating resolution of the infection and minimizing the morbidity and mortality of the infection. Nephrectomy may be required if there is no function in the affected kidney. About longer period of antibiotic therapy is usually required. Chronic pyelonephritis. Chronic pyelonephritis results from repeated renal infection which leads to scarring, atrophy of the kidney and subsequent renal insufficiency. The diagnosis is made by radiologic or pathologic examination rather than from clinical presentation. Many individuals with chronic pyelonephritis have no symptoms, but they may have a history of frequent UTI. In children, there is a strong correlation between renal scarring and recurrent UTIs. The developing kidney appears to be very susceptible to damage, and this susceptibility appears to be age-dependent. Renal scarring included by UTIs is rarely seen in adults' kidneys. Patients with chronic pyelonephritis are often asymptomatic. Diagnosis is made incidentally when radiologic investigation is initiated to evaluate for the complications associated with renal insufficiency such as hypertension, visual impairments, headache, fatigue, and polyuria. Urinalysis may show leukocytes or proteinuria. Serum creatinine levels reflect the severity of the renal impairment. Urine cultures are only positive when there is an active infection. These are the images of DMSA scan for the left and for the right we can see voiding cysto-urethrogram. How do we perform voiding cystogram? We put the urethral catheter to the patient's urinary bladder. We fill the urinary bladder with the help of that catheter, and after filling the urinary bladder, we get X-ray images. And if there is a from the bladder to kidney reflux, then on the X-ray image we see the contrast goes up to the kidney, such in this right image. Management. The management of chronic pyelonephritis is somewhat limited because renal damage incurred by chronic pyelonephritis is not reversible. Eliminating recurrent UTIs and identifying and correcting any underlying anatomic and functional urinary problems such as obstruction or urolithiasis can prevent further in renal damage. In children, evaluation for vesicoureteral reflux with a voiding cystourethrogram is important to eliminate risk factors for recurrent pyelonephritis and renal scarring. Long-term use of continuous prophylactic antibiotic therapy may be required to limit recurrent UTIs and renal scarring. Rarely, removal of affected kidney may be necessary due to hypertension or having a large stone burden in a non-functioning kidney. Renal abscess. Renal abscess result from severe infection that leads to liquefaction of renal tissue. This area is subsequently sequestered, forming an abscess. They can rupture out into the perinephritic space, forming perinephritic abscesses. When the abscess extended beyond the gerontofascia, paranephritic abscess develops. Historically, most renal and perinephritic abscesses result from hematogenous spread of staphylococci, in particular form of infected skin lesions. Patients with diabetes, those undergoing hemodialysis or intravenous drug abuses were at high risk of developing renal abscesses. With the development of effective antibiotics and better management of diseases such as diabetes and renal failure, renal or perinephritic abscess due to gram-positive bacteria are less prevalent. Those caused by E. coli or Proteus species are becoming more common. Renal abscess can form from hematogenous spread as well as urinary tract abnormalities such as stone or obstruction. Presentation and finding. The most common presenting symptom in patients with renal perinephric abscess include fever, flank or abdominal pain, chills and dysuria. Many of the symptoms have lasted for more than 2 weeks. Flank pain may be palpated in some patients. Urinalysis usually demonstrates white blood cells. However, it may be normal in some cases. Especially we see normal urinal analysis in complete obstruction from the stone or from the other causes. Urine culture may identify the causative organisms. Radiographic imaging. Renal abscess can be accurately detected using ultrasonography or CT scans. CT scan can demonstrate an enlarged kidney with focal areas of hypoattenuation early on duration of the course of infection. Once the inflammation wall forms around the fluid collection, the abscess appears as a mass with a rim of contrast enhancement. CT scan may also demonstrate thickening of gerontofascia. IVP are less sensitive tests in detecting renal perinephritic abscess. This is the image shows the renal abscess on the right kidney. white arrow shows the abscess. Management. The appropriate management of renal abscess first must include appropriate antibiotic therapy, because it's often very difficult to identify the correct causative organisms from the urine or blood. Empiric therapy with broad-spectrum antibiotics is usually recommended. If the patient doesn't respond within 48 hours of treatment, percutaneous drainage under computed tomography or ultrasound guidance is indicated. The drained fluid should be cultured from the causative organisms. If the abscess still doesn't resolve, then open surgical drainage or nephrectomy may be necessary. Follow-up imaging is needed to confirm resolution of the abscess. Xanthogranulomatous pyelonephritis. XGP is a form of chronic bacterial infection of the kidney. The affected kidney is almost always hydronephrotic and obstructed. In many cases, XGP occurs unilaterally. Severe inflammation and necrosis obliterate the kidney parenchyma. Presentation and finding. Patients with XGP commonly present with flank pain, fever, chills, and persistent bacteriuria. A history of urolithiasis is present in about 35% of the patient. On physical examination, flank mass can be often palpated. Urinalysis commonly demonstrates white blood cells and protein. E. coli or Pseudomonas proteus species are commonly cultured from the urine. Because XGP primarily occurs unilaterally, azotemia or renal failure is not often seen. CT scan is the most reliable method in imaging patients suspected of having XGP. It usually demonstrates a large heterogeneous reniform mass. The renal parenchyma is often marked with multiple water density lesions and representing dilated calyces or abscess. Ultrasonography doesn't provide information. In this image, we see the image of xanthogranulomatous pyelonephritis. Here we see computed tomography. On the left side, we see enlarged kidney due to xanthogranulomatous pyelonephritis. This arrow shows big stone located in ureteropelvic junction and also obstructed the urine outlet. On this arrow, this arrow shows us the placed percutaneous nephrostomy tube, and those are the xanthoma cells. We can see in this computed tomography scan, and this is the image of after nephrectomy. Management. The management of xanthogranulomatous pyelonephritis is dependent on accurate diagnosis. In some cases, XGP is misdiagnosed as a renal tumor. Nephrectomy is performed and a diagnosis is made pathologically. In those in whom a diagnosis of xanthogranulomatous pyelonephritis is suspended, kidney-sparing surgery such as a partial nephrectomy is indicated. However, when the infection is extensive, a nephrectomy with extension of all involved tissues is warranted. There are reported cases of treating XGP with antibiotic therapy alone or in combination with percutaneous drainage. However, these treatments are not likely to be curative. Pyonephrosis. Pyonephrosis refers to bacterial infection of a hydronephrotic obstructed kidney which leads to suppurative destruction of renal parenchyma and potential loss of renal function. Patients with pyelonephrosis are usually very ill with high fever, chills, and flank pain. Lower tract symptoms are not usually present. Bacteriuria and pyuria may not be present when there is a complete obstruction of the affected kidney. Imaging with renal ultrasonography or computed tomography scan diagnose pyelonephritis. Renal or ureteral calculi may also be identified on CT scan or ultrasonography. This ultrasonography shows pyelonephrosis. This white arrows shows the big, huge-sized fluid debris level within dilated renal pelvis. Management of pyelonephrosis include immediate institution of antibiotic therapy and drainage of the infected collecting system. Broad-spectrum antimicrobials are indicated to prevent sepsis while the causative organisms is being identified. Antibiotics should be started before manipulation of the urinary tract. Performing drainage of the obstruction through the lower urinary tract, such as using a urethral stent, should be reserved for a patient who are not septic. Extensive manipulation may rapidly induce sepsis and toxemia. In septic patients, drainage of the collecting system with a percutaneous nephrostomy tube is preferable. Once the infection is treated, conditional imaging evaluation is required to identify the cause of the urinary tract obstruction, such as urolithiasis or uretero-pelvic junction obstruction. And now we will start to talk about cystitis. Acute cystitis refers to urinary infection of the lower urinary tract, principally the bladder. Acute cystitis more commonly affect women than men. The primary mode of infection is ascending from the periurethral, vaginal, and fecal flora. Patients with acute cystitis present with irritative voiding symptoms such as dysuria, frequency and urgency, low back and suprapubic pain, hematuria, and cloudy, foul-smelling urine are also common symptoms. Fever and ischemic symptoms are rare. Typically, urinalysis demonstrate white blood cells in urine and hematuria may be present. Urine culture is required to confirm the diagnosis and identify the causative organisms. E. coli causes the most of the acute cystitis. Other gram-negative and positive bacteria are uncommon pathogens. In uncomplicated infection of the bladder, radiologic evaluation is not often necessary. Management for acute cystitis consists of a short course of oral antibiotics. Trimethoprim, sulfamethoxazole, nitrofurantoin, and fluoroquinolones are commonly used antibiotics for treatment. Recurrent cystitis and UTIs. Recurrent cystitis UTI is caused either by bacterial persistence or reinfection with another organisms. Identification of the cause of recurrent infection is important. When bacterial persistence is suspected, cause of radiologic imaging is indicated. Ultrasonography can be obtained to provide a screening evaluation of the genito-urinary tract. More detailed assessment with IVP, cystoscopy, and CT scans may occasionally be necessary. When bacterial reinfection is suspected, cause of recurrent cystitis, the patient should be carefully evaluated for evidence of vesicovaginal or vesicoenteric fistula. Management of recurrent cystitis again depends on its course. Surgical removal of the infected source, such as urinary calculi, is needed to treat bacterial persistence. Similarly, fistulas need to be repaired surgically to prevent bacterial reinfection. In most cases of bacterial reinfection, medical management with prophylactic antibiotics is indicated. Low-dose continuous prophylactic antibiotic has been shown to reduce the recurrences of UTI most of the time. When the recurrent cystitis or UTI is related to sexual activity, frequent emptying of the bladder and a single dose of antibiotic taken after sexual intercourse can significantly reduce the incidence of recurrent infection. Acute bacterial prostatitis. Acute bacterial prostatitis refers to inflammation of the prostate associated with a UTI. It is thought that infection results from ascending urethral infection or reflux of infected urine from the bladder into the prostatic ducts. In response to bacterial invasion, leukocytes are seen within a surrounding tissue surrounding the acini of the prostate. Edema and hyperemia of the prostatic stroma frequently develop. With prolonged infection, variable degree of necrosis and abscess formation can occur. Presentation and findings. Acute bacterial prostatitis commonly affects adult men. It is the most common urologic diagnosis in men younger than 50 years. Patients with acute bacterial prostatitis usually present with an abrupt onset of constitutional and urinary symptoms. The symptoms include fever, chills, malaise, arthralgia, myalgia, lower back, rectal, perineal pain, frequency, urgency, dysuria. This may also present with urinary retention due to swelling of the prostate. Digital rectal examination reveals tender, enlarged glands that are irregular and warm. Urinalysis usually demonstrates white blood cells and occasionally hematuria. Serum blood analysis typically demonstrate leukocytosis. PSA levels are often elevated. The diagnosis of prostatitis is made with microscopic examination and culture of the prostatic expressate and culture of urine obtained before and after prostate massage. In the patients with acute prostatitis, fluid from the prostate massage often contains leukocytes. However, at the onset of acute prostatitis, prostatic massage is usually not suggested because the massage may lead to bacteremia. Similarly, urethral catheterization should be avoided. Culture of urine and prostate expressate usually identifies organisms. E. coli is the most common causative organisms in patients with acute prostatitis. Other gram-negative bacteria and enterococci are less frequent pathogens. Radiologic imaging is rarely indicated in patients with acute prostatitis. Bladder ultrasonography may be useful in determining the amount of residual urine. Transrectal ultrasonography is indicated only in patients who do not respond to conventional therapy. Treatment with antibiotics is essential in the management of acute prostatitis. Empiric therapy directed against gram-negative bacteria and enterococci should be instituted immediately while awaiting the culture results. Trimethoprim and fluoroquinolones have high drug penetration into the prostatic tissue and are recommended for 4 to 6 weeks. The long duration of antibiotic treatment is to allow complete sterilization of the prostatic tissue to prevent complications such as chronic prostatitis and abscess formation. Patients who have sepsis, are immunocompromised or in acute urinary retention or have a significant medical comorbidities would benefit from hospitalization and treatment with parenteral antibiotics. Aminoglycosides also provide effective therapy against both gram-negative bacteria and enterococci. Patients with urinary retention secondary to acute prostatitis should be managed with a suprapubic catheter because transurethral catheterization or instrumentation is contraindicated. Chronic bacterial prostatitis. In contrast to the acute form, chronic bacterial prostatitis has a more insidious onset, characterized by relapsing, recurrent UTI caused by the persistence of pathogen in the prostatic fluid despite antibiotic therapy. Most patients with chronic bacterial prostatitis typically present with dysuria, frequency, urgency, nocturia, and low back perineal pain. These patients usually are afebrile and not uncommonly have a history of recurrent UTI, urethritis, or epididymitis caused by the same organism. In patients with chronic bacterial prostatitis, digital rectal examination of the prostate is often normal. Occasionally, tenderness, firmness, or prostatic calculi may be found on examination. Urinalysis demonstrates a variable degree of white blood cells and bacteria in the urine. Serum blood analysis normally doesn't show any evidence of leukocytosis. PSA level may be elevated. Diagnosis is made after identification of bacteria from prostate expressate. The causative organisms are similar to those acute bacterial prostatitis. Radiologic imaging is rarely indicated in patients with chronic prostatitis. Transrectal ultrasonography is only indication if a prostatic abscess is suspected. Antibiotic therapy is similar to for that acute bacterial prostatitis. Interestingly, the presence of leukocytes or bacteria in the urine and prostatic massage doesn't predict antibiotic response in patients with chronic prostatitis. In patients with chronic bacterial prostatitis, 3 to 4 weeks of using fluoroquinolones generally effective for treatment. The addition of an alpha blockers and anti-inflammatory agent to antibiotic therapy has been shown to reduce symptom recurrences. Despite maximum therapy, cure is not always achieved due to poor penetration of antibiotics into prostatic tissue. Third-line agents include 5-alpha reductase inhibitors, glycosaminoglycans, and saw-palmetto. Transurethral resection of the prostate has been used to treat patients with refractory disease. However, this approach is not generally recommended. Prostate abscess. Most cases of prostatic abscess result from complication of acute bacterial prostatitis that were inadequately or inappropriately treated. Prostatic abscess are often seen in patients with diabetes, those receiving chronic dialysis, or patients who are immunocompromised. Patients with prostatic abscess present with similar symptoms to those with acute bacterial prostatitis. Typically, these patients were treated to acute bacterial prostatitis previously with antibiotics. However, these symptoms recurred right after the treatment, suggesting development of prostatic abscesses. On digital examination, the prostate is usually tender and swollen. Fluctuance seen in some patients with prostatic abscess. Imaging with ultrasonography or pelvic computer tomography scan is crucial for diagnosis and treatment. Antibiotic therapy in conjunction with drainage of the abscess is required. Transrectal ultrasonography or CT scan can be used to direct transrectal drainage of the abscess. Urethral resection and drainage may be required if transrectal drainage is inadequate. When properly diagnosed and treated, most cases of prostate abscess resolve without significant concern. This ultrasound image shows the prostatic abscess. Urethritis. Inflammation of the urethra can be categorized into those types caused by Neisseria gonorrhea and other organisms such as Chlamydia trachomatis. Most causes are acquired during sexual intercourse. Patients with urethritis may present with urethral discharge and dysuria. The amount of discharge may vary significantly, from profuse to scant amounts. Obstructive voiding symptoms are primarily present in patients with recurrent infection, in whom urethral strictures subsequently develop. It is important to note that approximately 40% of patients with gonococcal urethritis are asymptomatic. The diagnosis is made from examination and culture of the urethra. It is important to obtain the specimen from within the urethra rather than just the discharge. Approximately 30% of men infected with gonorrhea will also have concomitant infection with Chlamydia trachomatis. Pathogen-directed antibiotic therapy is required. In patients with gonococcal urethritis, ceftriaxone intramuscularly or fluoroquinolones may be used. For patients with non-gonococcal urethritis, treatment with tetracycline or erythromycin or doxycycline for about 2 weeks. Epididymitis and orchitis. Causes of epididymitis and orchitis: infection and inflammation of epididymis most often results from ascending infection from the lower urinary tract, the infection in the epididymis, and may to involve the testes. Most cases of epididymitis orchitis in men younger than 35 years age due to sexually transmitted organisms such as gonorrhea and chlamydia. Those in children and older men are due to urinary pathogens such as E. coli in homosexual men and or who practice anal intercourse. E. coli and other coliform bacteria are common cause of organisms. Patients with epididymitis orchitis present with severe scrotal pain that may radiate to groin or flank area. Scrotal enlargement due to the inflammation of the epididymitis, testes, or reactive hydrocele may develop rapidly. Other symptoms of urethritis, cystitis, prostatitis may be present before or concurrent with the onset of scrotal pain. On physical examination, an enlarged and red scrotum is present, and it is often difficult to distinguish the epididymitis from the testis during the actual infection. A thickened spermatic cord can occasionally be palpated. Urinalysis typically demonstrates white blood cells and bacteria in the urine or urethral discharge. Serum blood analysis often reveals leukocytes. Frequently, it is difficult to distinguish epididymitis from acute testicular torsion based on the history and physical examination alone. Scrotal Doppler ultrasonography can be used to confirm the diagnosis. The presence of blood flow in the testis on Doppler ultrasonography rules out torsion. On scrotal ultrasonography, patients with epididymitis orchitis commonly have an enlarged epididymis or testis with increased blood flow. A reactive hydrocele may also be seen. Oral antibiotic treatment is directed against specific causative organisms. On urethritis and UTI, in addition, bed rest, scrotal elevation, and the use of non-steroidal anti-inflammatory agents are helpful in reducing the duration of symptoms. For patients with sepsis or severe infections, hospitalization and parenteral antibiotic therapy may be needed. Open drainage is indication in cases in which an abscess develops. Occasionally, patients with chronic relapsing epididymitis may require epidydymectomy or cectomy for relief of the symptoms. And now we have finished our first lecture. Thank you for your attention.